So you were in the session this morning. You probably heard from multiple speakers already, how cancer is actually a biggest challenge in a lot of the Asia country, especially the Southeast Asian or the developing country. Next. So I just want to flash this up and state that one of the biggest challenge in terms of cancer control in Malaysia is actually late-stage cancer presentation. And what I mean by that, so in terms of breast cancer, you can see it clearly on this figure here, while 86% of the UK population, or breast cancer cases in the UK, diagnosed at stage 1 and stage 2, where it's associated with more than 80% 5-year survival. But in Malaysia here, we have 48% of breast cancer actually diagnosed at stage 3 and 4, and you can see how the survival rate is actually half, right, compared to the early stage. And then what we need to be mindful here is breast cancer, most of the breast cancer actually is really a more curable and treatable disease. Why do we have so many people dying from breast cancer in Malaysia? The main contributor is actually the late stage presentation. And to make it worse, next slide, we can see that it is increasing in Malaysia, breast cancer incidence, and we're actually expected the highest rise in the Asian Pacific region. So that's scary. And what are we currently doing in terms of the cancer control? We go to the next slide. Basically, all we do is an opportunistic screening. We tell women to come forward for screening from the age of 50, every 2 to 3 years. So unlike in the UK where there's a population-based screening, when times come you receive a letter and then you will be told that it's your time, please come for the first screening, and then you'll be reminded that when will be your next screening. So this is not the case in Malaysia. And to make it worse, because it's opportunistic, the uptake rate of screening is actually very low in Malaysia. Actually only about 20 to 25 women ever attend mammogram screening. So what does that mean? That these 20-25% women, probably most of them take mammogram screening as a one-time thing in their lifetime. But we all know that for mammogram screening to be useful, you actually need to go back repeatedly, regularly, so you can pick up the cancer at the early stage. So if we go business as usual, if we don't do anything about it, the fact is in the next 10 or 20 years, more Malaysian women is going to die from breast cancer, mainly due to late-stage diagnosis. So after that scary statement, then the big question would be, will I be one of them, right? Or you may ask that, would my wife, my partner, my sister, my siblings, would there be one of them? So the key questions that we need to ask here is, what is my risk of breast cancer? Do I need to do anything about it? So that is the big questions that our team is actually trying to answer. Before we go on further, we need to understand risk, right? So whenever we ask about disease risk, or what's my risk of developing a certain disease, there's always a baseline risk. I think we need to be really, really clear about it. There's a baseline risk means that it depends on what's your ethnicity and where you live, right? If I'm a Malay living in Malaysia and I'm a Malay living in the US or in the UK, my baseline risk will be different. And then, not yet. So when you have this baseline risk, then you're going to identify factors that increase or decrease that baseline risk. And then what you're going to do is then put all these factors and weight and adjust them accordingly so you can combine all the information that you have and come up with a better risk estimate, or we call it personalized risk estimate. And of course, the ultimate goal of doing that is I want to ask the question or answer the questions on what can I do about it. So what does that mean? Say if your lifetime risk is 8%. So what does that mean? 1 in 20 Malaysian women will get breast cancer in their lifetime. That's about 5% risk. If I say that your risk is 8%, basically it means that if I bring 100 people together, they have the same age as you, same lifestyle, same genetic, everything is similar, I control for everything. And in the lifetime, 8 out of these 100 women will develop breast cancer. So I can't tell who, right? I can't tell who among the 100 will be the 8, but this is what we mean. We don't really predict the individual risk, but what we're trying to do is to identify this group of people who are similar, and we know that they have a higher risk, and hence we can do something about it. So next. So I was asked to talk about genetic. So among all the influence factors that I mentioned, one of it will be the genetic. So I just want to briefly walk us all through what do we now know about the genetic contribution or the risk associated with genetic in the Malaysian context. So okay, just stick with this one. So for this plot here, that two lines is really trying to separate the region. So the line itself means nothing here. So it really trying to separate the region, and what you're seeing on the y-axis is, how likely a certain genetic variant that you identified has a high impact on breast cancer risk. That's what the y-axis quantified, while the x-axis tells you that how likely you are going to see this genetic variant in the population. So if you think about it, what you have on the top, on your top left, the very rare and high risk means that these genetic variants, if you have it, it confers a very high risk of developing disease, but it is extremely rare in the population, probably less than 0.1%. So that's how you, interpret the plot. So everything outside the red line or below the blue line is something that either does not exist or is too hard to find. So my focus today is actually going to talk about roughly these three regions. Next. So this is the first study that published early this year. First study to quantify the risk associated with BRCA1, BRCA2 mutation in the Malaysian population. So we have some data in the Chinese population from China, but this is actually the first study that looked at the risk in Malay population and Indian population, and refining the risk for the Chinese population in Malaysia. So in a study of 572 families, which is the largest study in Asia. Next. So what do we find? This is what we found. First thing is, I want to bring your attention to the risk associated with BRCA carriers in the European population. If you look at the top right there, what you're seeing is for European, all this while we know, for European women, if this woman is a BRCA carrier, BRCA1 or BRCA2, that actually the risk associated with this mutation to get breast cancer risk is up to 72% for BRCA1 and 69% for BRCA2. So prior to this publication, what the doctor has been using, the risk estimate or number that we have been using to advise the BRCA carriers of Asian ancestry is actually based on the risk estimate for the European ancestry. And now looking at this figure, you know that it's actually not appropriate. If you remember what I said right at the beginning, everyone has a baseline risk, right? Our baseline risk is different. And because of this difference of baseline risk, even though I am a BRCA carrier, but you can see that I'm a Chinese woman, say I'm a BRCA carrier. If you look at the blue solid line, what you're seeing is my risk of getting breast cancer in my lifetime is 55%, compared to the one reported in the European is 72%. So it is not the same. So the key on this plot here is really our risk, lifetime or short-term or long-term risk, actually vary depending on our ethnicity. And we have to be very mindful here is all the numbers that you are seeing here is actually a lot lower than those that are reported in the European population. So what does that mean? Any risk management strategy that has been established based on the European population, we need to think about how can we refine that so it suits our population who has a lower lifetime risk. Then the next, I'm skip the middle region, and I'm going to talk about this region about these risk variants that are very common in the population. 20 to 50% of the people have it, but each of them actually confer very low risk. This is a new slide, so I attended a talk from a professor in the US, and I really love the way that she explained what is polygenic risk score. So let me try my luck, okay? Basically what she's saying is, imagine that now we have a deck of cards, right? And this deck of cards, if you're Chinese, you're getting a deck, different from Malay, who's going to getting another deck, okay? And you're going to have 330, let's say you're holding 333 cards, okay? Coming from this original deck of cards, I'm going to pick 333 cards of them. So what would the numbers on the cards look like? So I'm going to pick them out. So most people is going to get a mix, right? You have some high numbers and some low number. But there will be people who are unlucky, who get all the high numbers. Or you have people who are extremely lucky to get all the low numbers. And each of these numbers is actually associated with the impact on risk differently. So what researchers are trying to do now is individually, the impact is way too small. So what's matter is what is the total hand value, right? In total, what is the total number of your cards? But we don't just sum it up. What researchers has been doing now is trying to identify a better way to quantify all these numbers on these 333 cards. Well, I obviously don't do as good as the professor does, but I hope you get an idea of what exactly does it mean polygenic risk score. Basically, all it says is if I have 333 genetic variants that I tells you are important because they are associated with breast cancer risk, pretty sure that all of us would have some of it. Whether you have a lot or whether you have little does matter. So what do we find? So our team developed a tool based on these 333 genetic variants, and then we look at how we can use it to predict the risk of breast cancer in the general population. So we're no longer talking about the BRCA carriers, we're talking about this general population. And what do we see here is, so remember I said the card for most of the people will be a mix of high or low. So those are the people in the pinkish region right in the middle of the bell-shaped curve, but there will be people at the extreme right or the extreme left, okay? So what does that mean here is if I compare people who have a mix of high or low, I found that people who are extremely unlucky and having all these high numbers card, they are 3 times more likely to develop breast cancer compared to those who have a mixed number. Okay, this is not so useful if I just tell you that your number is in the yellow zone, your number is in the blue zone, right? We need to translate it into some things that, at least at this point, we think is most easy understand by the women or by the population. So this is what we have for the Chinese population as an example. What do we see here is the lifetime risk, I think this is Singapore population if I'm not mistaken, is around 6%, okay? Now what we're doing now is everyone has the same risk. Everyone has the 6% lifetime risk. But after we look at the polygenic risk score, based on just the genetic itself, we realize that this is not the case. If you go to the next. So the same color code that you are seeing earlier, if you happen to be the unlucky one and being in the yellow zone, that basically translated to 19% lifetime risk of developing breast cancer compared to the average 6% in the general population. So likewise, if you are the extremely lucky one and being at the bottom of the curve, actually your risk is a lot lower compared to the general population. Why would this be useful? Let's go back to mammogram screening. The key here is not saying from age 50 who should go for screening, right? It's more on for someone who is similar to me with this sort of risk in this group, when do we need to start screening and how often? So for those in the yellow zone, you may want to start them at age 35. But for those in the blue zone or purple zone, you may want to tell them that maybe you still come at age 50, but you don't have to come so regularly. And one of the key findings of our research is we are actually the first group to look at this one, is we see that the same genetic score with 333 variants are actually predictive across all ethnicity in Malaysia. But the key is their distribution is not the same. And what does that mean? If you now look at the top curve, which is for Malay, so all of them are generated using the same 333 genetic variants. So if you look at that dashed line, that's basically saying that, you know, for Malay, okay, if, I'm very nervous, 5 minutes, I know, I can finish, okay. If you have someone here, oops. So if you have someone at this line, suppose that you are a Malay, you fall into this zone, fall from the back, and your lifetime risk is supposed to be 8%. That's the correct risk. But what if the researcher or people would just say that, okay, I'm just going to use the curve from the Chinese population and try to group you accordingly. Then you're going to fall into the third group from the back. And what happened is now you're going to tell the Malay women, instead of 8%, you're going to tell the women that you have 9.4% risk of breast cancer. So you overestimate their risk because you're not mapping to the right curve. And this is even worse if you think about the European population, which is in the next slides. Very quickly. So this genetic risk score has been developed and has already been actually offered by a lot of genetic testing company. But imagine that now I just use the curve at the bottom, which is for the European women. and apply it across. So I know that these two work for everyone in Malaysia. But the problem is because they're not mapping me to the right population, at the end they will either overestimate or underestimate my risk. Next. Okay, final, last few slides. So this is a region that we haven't done much about. So there's this middle region that say there are some genetic variants that are rare in the population, but they confer moderate risk. So their risk is not as high as the BRCA1-2 mutation. So what we have is, what you can see in the mutation, in the European population, that suppose that you are, I think the green is POP2 carrier, your lifetime risk of developing breast cancer is 35%. So a lot higher, lower than the BRCA1-2 mutation, but a lot higher than the general population. But this is European population. Unfortunately, we don't have data for the Asian or the Malaysian population yet. Next. Okay, take-home message 1. I think the key is, the reason that I started with talking about the baseline risk, I think one of the key messages that I want to deliver is we need to understand that our baseline risks are not the same. So we cannot blindly just take whatever estimate that's provided or built on the European population and think that it will automatically apply to our population. Like I say, even I'm BRCA carrier, they are BRCA carrier, but we are not the same. Second thing is, in terms of the risk management, okay, now that we know that BRCA carriers in Malaysia actually has lower risk of breast cancer, that means that we're going to change the whole risk management strategy altogether. So I'm not an expert in this area, but what we are thinking is, if our risk is lower, can we continue to find modifier of risk? If we pump in lifestyle, if we pump in polygenic risk score into the BRCA carriers, we may be able to further stratify their risk. What does that mean? So instead of a Chinese woman with 55% risk of developing breast cancer in their lifetime, if now you take into account my lifestyle and my polygenic risk score, my risk may drop all the way to 20%. Then the way doctor is going to comment in terms of the risk management strategy is going to be different, right? Compare someone who has 70% risk of developing breast cancer. And the final one is, I talk about this many times. So PRS is useful in predicting risk in the Malaysian population and in an Asian population as a whole. But again, we cannot just take blindly of what's offered to us in any of the genetic testing company, right? So we need to think about what exactly are you mapping to? Are you mapping to my population that's applicable to me? So while we're talking about all of this, then go back to what I said earlier. I may not be able to predict the risk of individual people, but what we're trying to do is to identify this group of people who are very similar to each other and has a very high risk. So it's not about prediction, but enrichment. The key here is, I think one of the speakers this morning said that obviously in Malaysia, we won't be able to afford to offer all this cancer control or screening to every woman in Malaysia. But what we can do instead is actually identify this group of people and optimally allocate the resources to just this group of people. So what are the gaps? I think I mentioned most of it already. So we don't know. For the other rare but moderate risk gene, we need to continue to work on that. Can we further stratify the risk for BRCA1 and BRCA2 mutation carriers? And then, so I haven't talked about this PRS. One thing is what cut off. So what cut off? What are you going to do with the PRS? So general population is 6%. Is 8% too much? Or is 8% okay? Only if you're 10%, then you do something? Or would it be 9% that you need to do something about it? So we don't know the answer to that yet. A lot of the study in the West, they already started to look at how to implement PRS, how to tell women about PRS, how do we communicate risk to women. I think it's the final slide already. Can I have the acknowledgement slide? So these are our team. All right, they all contribute to whatever I presented today in some way. I always say that there's no mean for discrimination. We just end up to have a group of beautiful women. Thank you so much.